everyone. This is Hyunchul Shin working at Samsung Medical Center, Gangbuk, Seoul, Korea. Today I'm going to talk about destiny of cervical OPLL, and according to that, I also talk about how we choose surgical approach and treatment tactics. Generally, anterior complete removal of OPLL with or without corpectomy is known as the standard or classical procedure if it involves less than 3 levels. But we have to consider several other factors before surgery. Whether the involving level is less than 3 or more, whether the cervical sagittal alignment is kyphotic or lordotic, did the patients have severe axial neck pain preoperatively? What is patient's main symptom and sign, whether it is radiculopathy or myelopathy? This will be vary from time to time according to surgeon's preference, but usually an anterior approach is chosen in case with involving level is less than 3, and posterior approach to more than 3 levels. In cases with just 3 level disease, we have to consider other factors. Some other reports show that the 25 to 53% of high incidence of non-union in cases with anterior decompression and fusion with either corpectomies or discectomies of 3 or more levels. Other cases with OPLL involving the C1, C2, or below C7, we should choose posterior approach to avoid complications. In kyphotic cases, not only we cannot get the enough shifting effect even we did the decompressive surgery, it's because kyphosis is more likely to progress. Because my story is related to the destiny, in other words, changing course of OPLL, I would like to talk about OPLL cells and pathogenesis of OPLL progression. OPLL cells have been reported to possess several phenotypic characteristics of osteoblasts, that is, in vitro high alkaline phosphatase activity in cultures compared with normal spinal ligament cells. OPLL cells respond to the factors like transforming growth factors and prostaglandin I2. An immunohistochemical study showed enhanced expression of osteogenic protein and BMP7. Early clinical and epidemiological studies have suggested that the underlying cause of OPLL is multifactorial in nature, reflecting the interplay of numerous genetic and environmental factors like type 6 collagen alpha 1 chain. And how about mechanical stress? Several studies have established that the mechanical stress has definite effect on OPLL progression. This article was already published that prostaglandin I2 induced by mechanical stress would be the cause of OPLL progression in 2003. Mechanical stress is converted to a biomechanical response and may play a role in OPLL progression through the osteogenic induction in spinal. To infer, instability is proportional to mechanical stress, and mechanical stress is thought to be proportional to OPLL progression. In conclusion, it can be accepted that instability is proportional to OPLL progression. As we know, the instability of laminectomy or laminoplasty state is larger than that of posterior fusion. If so, theoretically, OPLL progression rate of fusion will be lower than that of laminoplasty. This article showed that laminoplasty group OPLL progression rate is higher than that of conservative group in 450 cases with more than 10-year follow-up cohort study. In 2016, Professor Lee also insisted the similar results in their article. The laminectomy and fusion group had lowest progression rate, followed by laminoplasty group and laminectomy alone group. Segmental range of motion of more than 5 degree and OPLL types with disc space involvement like mixed type or continuous type, and younger ages below 60, while the elderly patient have a relatively lower range of motion because of cervical spondylotic changes, were significant predictors of OPLL progression. In 2018, we studied the effect of posterior fusion on growth of cervical OPLL using 3D volume measurement. 341 patients of multi-level cervical OPLL who underwent the surgery posteriorly by me and Professor Yoon Ha were enrolled in this study. The OPLL volume was measured from the C1 vertebra to the C7 vertebra, and the OPLL volume was measured for each vertebra. OPLL volumes of vertebra at the surgical and non-surgical levels were also calculated. Scatter plot of OPLL volume change between the most recent CT scan and preoperative CT in both laminectomy and fusion group and laminoplasty group. Volume change of laminectomy fusion group is smaller than that of laminoplasty group. Now I will show you the interesting case. This 49-year-old gentleman was admitted with the complaint of quadriplegia after slip-down injury. The MRI showed a severe cervical stenosis with OPLL extend to the lower portion of T1. These are the CT scans of this patient. Also, severe OPLL with sharp edges can be observed on CT scan. I did the laminectomy and posterior fusion from C2 to T3. On CT scan, you can see the difference between the two. Post-operative CT scan showed that the severe OPLL is slightly reduced, but not much as MRI scan, as it appears to be reformed from insufficient. I will show you another 44-year-old female case. The MRI showed severe stenosis with OPLL from C3 to upper part of C7, and CT scan showed severe OPLL like this. I did the laminectomy with the posterior fusion surgery from C3 to C7. This MRI also showed decreased size of OPLL with the lower signal intensity compared to pre-op MRI. CT scan also showed softly reforming shape of OPLL with the lower Hounsfield unit density. I've been calling this phenomenon of a demineralization ever since. We can imagine that if we remove the minerals from normal bones, it becomes soft bone and it cannot resist compression. It is speculated that the demineralization occurred as the strain on the bone itself was reduced due to long-term fusion. In conclusion, several studies have established that the mechanical stress and instability has definite effect on OPLL progression. posterior instrumented fusion suppressed OPLL growth compared to motion-preserving laminoplasty. Younger age and increased segmental motion were significant predictors of OPLL progression. Thank you for your attention.